Good evening, friends. Today we'll be talking about neuro-rheumatology. We'll be concentrating on neurosarcoidosis and primary anxieties of central nervous system. I'll deal more with this. Then systemic lupus erythematosus, APL syndrome, and Bechets. And these are the items which we're going to discuss today. So the scheme will be, first we'll discuss about neurosarcoidosis, then PACNS to a great extent, SLE also in some detail, and antiphospholipid syndrome and Behçet's disease on brief. So neurosarcoidosis is sarcoidosis as such is an inflammatory multisystem disorder characterized by non-necrotizing granulomatous inflammation histopathologically. As you can see in this granulomatous inflammatory reaction, and there are multinucleate giant cells also. Other granulomatous diseases that are often considered in the differential diagnosis include tuberculosis or other mycobacterial infections, fungal infections, granulomatosis with polyanxieties, and chronic granulomatous disease of combined variable immunodeficiency. So these are some of the differentials that will come into that. More of it later. And you see the PET scan, and the PET scan has seen the granulomas in the liver, in the lymph nodes, in the mediastinum, also in the spinal cord. So this is the PET scan which characterizes that. So in neurosarcoidosis, the central nervous system involvement includes cranial neuropathies mostly, most common. And second presentation is subacute chronic meningitis. Vasculopathy or vasculitis, and there is some autopsy evidence towards vasculopathy than vasculitis. Myelopathy and myelitis, which will mimic the long segment myelitis of anti-aquaporin antibody disease or NMOSD. Infiltrative pituitary lesions, which can lead to endocrine disturbances, and intraparenchymal mass lesions. In peripheral nervous system involvement is myopathy. Neuropathy with axonal sensory-motor polyneuropathy being the most common type. So neuraxis, the whole neuraxis can get involved. You can see the meninges, both leptomeninges as well as the dura can be affected in 10 to 20% of the patients, which can manifest as an inflammatory and obstructive process in the CSF. That means it's going to give rise to hydrocephalus. So you can see that, you can see in this picture, and inflammatory and obstructive, these are the meningeal involvements. Meningeal enhancement can be nodular and diffuse, and it can be seen all around the brain parenchyma. An aseptic meningitis, generally with a lymphocytic pleocytosis, has been noted in about 20% of patients and up to 20%. Dural thickening, which is called pachymeningitis, as you can see, this can occur in this patients. The meningeal involvement, as I said earlier, gives rise to hydrocephalus, which can be seen in 10% of the cases. That's because it can be non-communicating due to an obstructive process such as granuloma formation, which can obstruct the drainage of the CSF, or it can be communicating. This is due to scarring of the arachnoid villi in the granulomatous inflammation. So all these things will interfere with proper CSF reabsorption and cause that. And parenchymal involvement, as you can see here, is noted in about 50% of neurosarcoid patients, can manifest as white matter and cortical lesions, as you can see in these diagrams, can radiographically mimic demyelinating disease, and you can think that it could be NMOSD and things like that. So there is a lot of confusion about this because it's also autoimmune disease. It's also associated with antibodies. And the hypothalamic involvement you can see here. This is the hypothalamic involvement, and this is the third ventricle, this is the lateral ventricles. In the coronal section, this is the SAD section. Another important manifestation of parenchymal disease to consider is the invasion of the hypothalamic and pituitary regions. This can have far-reaching effects on the neuroendocrine function and on the secretion of ADH, thyroid hormone, cortisol, and sexual hormones, and so on and so forth. So this is another important issue. Myelopathy, you can see very interesting myelopathy, and you can see that this is a type of long segment myelopathy, which we always think could be because of NMOSD, but it can be seen here. It can be seen here. There is a difference between sarcoid and this is a patient 2 which has got similar finding. The involvement of the spinal cord can take place in different radiographic patterns, including patchy intramedullary lesions, longitudinally extensive transverse myelitis, intradural extramedullary disease, as well as extradural disease. But there is a difference in the involvement, which you can see, which we are going to explain next. In aquaporin 4 and NMOSD, it is the central myelitis, the gray matter that is involved totally. You can see in the axial section of the spinal cord. Whereas in sarcoidosis, you see that this is a type of involvement it comes. It's not exactly covering the central gray matter. And of course, you can establish by PET scan, which shows the spinal cord involvement, which is not present in cases of NMOSD. So subpial enhancement, 62% in Neurosarcoid, as well as 12% in NMO. Ring enhancement is more common with NMO. Spinal PET, 50% it is shown, as shown here, but 0%, no small 0%, I mean, so far in the small sample study, which is published in Annals of Neurology. And low glucose is common with the Neurosarcoidosis as compared to in this study. There are some discriminating features of long myelitis of neuromyelitis optica from sarcoidosis as shown here. So we have to keep that in mind in differential diagnosis. So the diagnostic criteria include clinical and diagnostic evidence suggestive of neurosarcoidosis as by MRI, CSF, and narrow conduction studies typical of granulomatous disease after rigorous exclusion of other causes, and nervous system pathology is consistent with neurosarcoid. In this, extraneural sarcoidosis is evident is type A, and if it is not evident, isolated CNS sarcoid is type B, and a probable one, pathologic confirmation of systemic granulomatosis disease consistent with sarcoidosis along with other features. There is no pathological confirmation, then you are only suspect, and then it becomes possible. So these are the diagnostic criteria which were published in JAMA Neurology in 2018. So the diagnostic workup, because of these diagnostic criteria, the CSF findings will be elevated opening pressure, elevated CSF protein in 62%, lymphocytic pleocytosis in 57%, and positive oligoclonal bands 19%. So we'll have to really differentiate it from multiple sclerosis. CSF angiotensin converting enzyme is controversial, and it is low specificity and sensitivity. Maybe normal in 30% of patients with neurosarcoid CSF. Imaging may help. Chest imaging in 90% will be abnormal. High resolution HRCT chest with contrast is recommended, and FDG PET scan may be helpful to detect extrapulmonary sarcoidosis. That's the diagnostic workup. The treatment, intravenous methylprednisolone followed by a slow, prolonged prednisolone taper is considered first-line treatment. Don't be in a hurry to taper of steroids. So you have to taper very slowly, maybe 5 milligrams or 10 milligrams per month. Often when there is neurological involvement, the disease requires prolonged therapy. So steroid sparing agents may be required at a later stage. However, the use of TNF-alpha agents, this is the mechanism is that tumor necrosis factor is released by macrophages, and it plays a critical role in the granuloma formation. So the infliximab, which is a chimeric mouse human monoclonal antibody, IgG1 antibody, is directed against TNF-alpha, and it induces complement-dependent and antibody-dependent cytotoxicity and apoptosis, inhibiting granuloma formation. And there are 2 studies which are infliximab for treatment of CNS sarcoidosis, 2 large retrospective studies which are published in neurology, neuroimmunology, and neuroinflammation of neurology. And these cases you can see are remission in 28 cases in 70%. In 66, it is improvement in 77%. So infliximab is a promising drug in neurosarcoidosis. So that takes us to the next major topic which we are going to deal today is central nervous system vasculitis. And it is seen clinically as an insidious, progressive, subacute encephalopathy and strokes. It's a broad, heterogeneous group of diseases resulting in inflammation and destruction of the blood vessels. There are 2 varieties here. primary anxieties of CNS, that is PACNS, secondary CNS vasculitis, systemic inflammatory or infectious processes, rheumatological diseases, and connective tissue disorders also can cause. So, but we'll be dealing mostly with PACNS, but we'll definitely touch on other varieties also. So there is no classical presentation of CNS vasculitis to understand that many other conditions may mimic vasculitis. The most patients with vasculitis, they present with confusion and fluctuating headaches. The clinical presentation will be involvement of many regions of the brain, fluctuating symptoms, stroke-like events, cortical symptoms like seizures, and memory disturbances, cognitive dysfunction, confusion, severe headache, etc. Radiological involvement of both white and gray matter, as you can see in this. So these are the pictures which we will keep on seeing in this presentation. So acute presentations with stroke, recurrent strokes, and TA is seen in about 31%, 30 to 50% of the cases. ICH is also encountered in 8% cases. There may be subacute presentations with headache, chronic headaches, encephalopathy, focal deficit, strokes, seizures, chronic meningitis, and rarely myelopathy. Primary CNS anxieties of CNS is far less common than the secondary causes of vasculitis. So a mimic workup is very necessary. CNS vasculitis must always be considered with strokes of different ages and different territories. That's very important to know about that. If you are encountering strokes of different ages and also in different territories, you should look at CNS vasculitis. So there is inflammation and destruction of the blood vessels of the brain, spinal cord, meninges. What is anxieties? Anxieties refers to both arteries and venules involvement. Primary anxieties of CNS is confined to CNS, whereas secondary CNS vasculitis occurs in association with a systemic inflammatory disease, systemic vasculitis, SLE, or infections such as herpes zoster. PACNS, as we call primary anxieties of CNS, is characterized by a long prodromal period. It can affect any part of the CNS, causing highly variable and non-specific clinical manifestations. It is originally viewed as a uniform, highly fatal, but now it is recognized as heterogeneous and treatable if detected early. So CNS involvement of primary vasculitis, that is not the, this is a part of the rheumatological disorders, includes microscopic polyanxieties, Wegener's granulomatosis with polyanxieties, Schuch-Strauss syndrome, and PAN. So these are the primary vasculitides. Apart from the rheumatological disorders and infections, these primary vasculitides are different from primary anxieties. Anxieties is where you have involvement of both arteries and venules. And these interesting entities are described to some extent. So let us first understand what is this vessel anatomy. The types of vessels that are defined as large vessels, medium vessels, and small vessels in the Chapel Hill Consensus Conference nomenclature system is in reference to kidney. The kidney is used to exemplify medium and small vessels, as you can see here. Large vessels are the aorta and its major branches and the analogous veins. The medium vessels are the main visceral arteries and the veins and their initial branches. And small vessels are intraparenchymal arteries, arterioles, capillaries, venules, and veins. So that's how we describe them. I'll show you another diagram. We can see large vessel vasculitides. This is the large vessel aorta, Takayasu and giant cell arteritis, and medium vessel vasculitides, that is PAN and Kawasaki disease. Immune complex small vessel vasculitides is cryoglobulinic vasculitis, Enoch-Schonlein purpura, and hypocomplementaremic urticarial vasculitides, and anti-GBM disease, that is good pasture syndrome. But what we are interested in is ANCA-associated small vessel vasculitides, which has got three important things which have got neurological significance: microscopic polyanxieties, and earlier what we used to call Wegener's is nowadays known as granulomatosis with polyanxieties, and eosinophilic granulomatosis with polyanxieties earlier was known as Schuch-Strauss syndrome. So the eponyms of these things have been done away with. So whenever we have some features which will tell us that, they caution us that there are possibilities, constitutional symptoms of fever, weight loss, malaise, arthralgias, arthritis, they are common to all vascularities of all vessel sizes. Large vessel vascularitis has got peculiarly limb claudication, asymmetric blood pressures, absence of pulses and bruise and aortic dilatation. The medium ones have got cutaneous nodules, ulcers, livido reticularis, digital gangrene, mononeuritis multiplex, and microaneurysms. What does the small vessel vascularitis has? Purpuras, vesiculobulbous lesions, urticarias, glomerulonephritis, alveolar hemorrhage, that is both are together known as Goodpasture syndrome, cutaneous extravascular necrotizing granulomas, splinter hemorrhages, scleritis, episcleritis, and uveitis. So these are the clues when we are having a neurological problem and to tell us that vasculitis is there underlying. So ANCA-associated vasculitis, or AAV, the eponyms were removed. And so, as I said earlier, now it is granulomatous polyanxieties, or GPA is Wegener's, microscopic polyanxieties, or MPA, eosinophilic granulomatous polyanxieties, the Strook-Strauss syndrome. These primary systemic vascularities are characterized by quasi-immune necrotizing of vasculitis of small to medium-sized blood vessels, and they are associated with serologically detectable ANCAs in majority of cases. So now this is a big group which you have to remember, ANCA-associated vasculitis, AAV. And look at the Wegener's and GPA. 51% of the patients had neurological involvement at DPA diagnosis, and these people can have headaches in 66%, sensory features in 42%, motor features in 31%, pachymeningitis in 51%, infarcts 43%, ICH 6%, hypophyseal involvement in 6%. So these are the important aspects, neurological aspects of Wegener's, which can be a presenting feature. And we already know that what are the features of medium and small vessels, other systemic features. The eosinophilic granulomatosis with the polyanxieties, and the patients with, there is Strook-Strauss earlier, patients with asthma, allergic rhinitis, pulmonary infiltrates, and peripheral eosinophilia are the characteristic features. The asthma and atopy, they precede the frank vasculitis by several years. The vasculitic phase commonly affects the skin and the peripheral nervous system. Rarely subarachnoid hemorrhage, ICH, and ischemic stroke are reported, and as brought out in Medicine Baltimore and Journal of Neurology in 2008. So the Bechets syndrome, I'm not going to deal now, we'll deal in the end. So the giant cell arteritis is the other CNS vasculitis primary. Its stroke is uncommon in giant cell arteritis. It occurs only in 2%. The intracranial vessel involvement is rare. It is a very rare cause of stroke. Strokes are common in vertebrobasilar territory, if at all they happen. Ophthalmic artery ischemia at diagnosis is the best predictor for GCA. GCA doesn't bother us much, but Takayasu arthritis, the pooled stroke and TAA prevalence rate is 15%, or 15.5, you can say 16%. But the type of stroke is not well defined. Stroke as a first manifestation of Takayasu arthritis is rare, but can be considered as etiological factor in stroke in young. So we should keep in mind, as I said, we are not going to discuss much about them, but we are going to discuss more about primary anxieties of central nervous system. These diagrams which are shown here, the blood vessel which is infiltrated with so many neutrophils, and the angiography and the lesions on the brain. So initially it was reported in 1959 as a pathological finding on autopsies. It's very rare. Annual incidence rate is about 2.4 cases per 1 million person years. The mean age is 50 years. You can see the non-infectious granulomatous anxieties predilection of the nervous system. It's published in neurology. And the Salvarani et al. Primary central nervous system vascularitis analysis of 101 patients we'll discuss at a later stage. So let us look at this PSCNS, which we said is a very rare disease. 2.4 per about 1 lakh person years, male are more common, 2:1. Median age, as we said, is 50 years, but it can occur at any age. Granulomatous vasculitis limited to the nervous system that may cause either focal or diffuse neurological involvement. Diffuse means cognitive dysfunction. Focal means strokes. And lymphocytic pleocytosis in CSF. So CSF is a very important aspect of diagnosis of PACNS. This disease, by definition, lacks systemic manifestations. The systemic manifestations of fever, loss of weight, these are all absent in PACNS. Signs and symptoms of untreated PACNS progress over months. In one series, the mean time period is 170 days. Diagnosis is very challenging. Symptoms are non-specific, and there is no diagnostic test that is 100% sure. The etiology of PACNS is unknown. There is inflammation that causes thrombosis and infarcts, especially in the cerebral cortex and leptomeninges than in subcortical region. Blood vessel supplying cranial nerves also may be involved. Now, what we know is that headache, which is the subacute in onset and insidiously progressive, is the most common reported symptom in 67% cases. Other symptoms include cognitive impairment, stroke on TAA in 30 to 50%, more than a single stroke in various anatomical locations, as I said earlier. The signs and symptoms of systemic vasculitis, such as peripheral neuropathy, fever, weight loss, or a rash, they are lacking here in PACNS. That's an important point to remember. Primary anxieties of central nervous system is suspected when you have recurrent strokes in young individuals, or stroke in young with no risk factors, no cardiovascular or procoagulant abnormalities, or no other predisposing factors. Development of cognitive function with or without headache is another presentation. Recurrent or persistent neurological dysfunction is another clue. Unexplained spinal cord dysfunction not associated with systemic disease is another presentation. In all these things, PACNS is suspected. So we have to have a heightened pretest probability. Approach to patients suspected to have CNS vasculitis depends on pretest probability. That is the clinical context in which we are looking at them. The clinical case series and cohort suggested to us that, firstly, a patient with multiple strokes in multiple vascular territories experienced over time is one clue. Second, in patient with both focal, that is strokes and paresis, and diffuse, altered cognition, sensorium, etc., is second presentation. Lastly, in any patient presenting with a chronic aseptic meningitis type of presentation. So these are the pretest probabilities. When we think of that, we should keep in mind, again, I show you something else. Highest pretest probability is chronic meningitis, recurrent focal deficits, unexplained focal and diffuse neurological dysfunction. However, clinical features of isolated anxieties of the central nervous system include headaches, encephalopathy, behavioral changes, focal motor sensory abnormalities, ataxia, cranial neuropathies, visual changes, myelopathy, and radiculopathy. But how did we come to all this knowledge? This knowledge is very difficult to acquire. It was acquired over course of decades. That's I would like to describe the 7 heuristics of CNS vasculitis. One is heuristics means it refers to experience-based techniques of problem solving. When we encounter that experience counts. Heuristic 1 is there is no specific clinical finding or sets of findings with sufficient pretest probability to secure a diagnosis of PACNS. So PACNS has evolved over the cohort studies from 1922 to 59, then 83 to 88, 90 to 97, 1988 Calabresi, and we'll see the diagnostic criteria flowed by them. And you got the 1988 to 2015, and where RCVS differential diagnosis has entered 2004 to 15. So this Salazar and all in 2019 from India, they presented the large series from India, which they have studied over 15 years. The continued research, the networks, the registries, pathophysiological studies should guide us to better diagnostic modalities. So these are the studies, the cohorts of PACNS over which we base our knowledge is Mayo Clinic cohort, French one, and Indian cohort by Dr. Saleja and the team from the Sri Chitra Institute of Medical Sciences. So what did they say? The Cns vasculitis, all patients of Selvarani et al., which is published in 2007, 101 patients, and most of the symptoms what I described, they have done, but they have diagnosed by biopsy and by angiography. So which is the modality with which we should diagnose? That we'll answer in a couple of slides later. In Mayo Clinic, the largest, this is the Selvarani is 101 patients, 70 angiography and 31 biopsy proven. Incidence, they said is 2.4 for 1 lakh, and their age is 47, and highest is 84, and lowest, youngest is 17. The duration of disease is 6 months before they could diagnose. CSF cells are elevated in biopsy and in angio in 4 cases. Protein in biopsy 98 cases and 54 in angio cases. Bilateral angiography changes in 81%. Favorable response to steroids is 81%, and there are only 26 relapses. That's how we gathered knowledge for the long observational studies. And as far as the Indian study, which is of 45 patients, and they did from 2000 to January to 2015 of December, 15 years, and they have comprehensively studied all the parameters that are recommended to be studied. And there are about 31 male patients and median age is 36. The initial presentation was stroke was the commonest clinical presentation, followed by headaches, seizures, and cognitive decline, as the numbers indicate here. And so this is the Indian study. And CSF is abnormal in 25, cell count is 0 to 60, protein level, and meningocortical biopsy was done in 29, was abnormal in 19, and lymphocytic pattern, necrotizing pattern, granulomatous pattern, which we are going to study in biopsy in future. That's how they found a lymphocytic pattern more common, that is in 11 cases. Poor outcome was seen in 26 or 27%, as you can say. Relapses occurred in 56%, and mortality is in 17% cases. And so there are some special subsets. If the heuristic one, that is the experience-based knowledge, CNS vasculitis with spinal cord abnormalities are implicated in about 5% patients. Angiography is negative. Biopsy is positive in primary CNS vasculitis. There may be leptomeningeal enhancement on MRI. That is another subset. Vasculitis with cerebral amyloid angiopathy. That's another subset. And this is very interesting because cerebral amyloid angiopathy can give rise to ICH, and solitary tumor like mass lesions and intracranial hemorrhage, which is seen in necrotizing type of vasculitis and ICH. So these are the special subsets. Heuristic 2, the laboratory investigations. The results of blood tests in patients with primary CNS anxieties or PSCNS are usually normal. There is ANA, ANCA, APL, ESR, CRP, all these are normal, negative. But what is the clue? Lumbar puncture is the key in the evaluation of PSCNS, and it is to be avoided only if mass effect is present. It is a very essential element of diagnosis to rule out the condition. In 95%, cells are raised and there will be up to 200, a protein will be less than 300. Patients with angiography negative primary CNS vasculitis often have greatly raised protein concentrations. See, the granulomatous anxieties has got more positive results in CSF, and that means it has a high negative predictive value. So CSF is a very important workup. It's a vital diagnostic tool. And because it's 90% abnormal lymphocytic pleocytosis, elevated protein, normal glucose, imaging often with ischemic infarcts, 53% of the cases, MRI is very sensitive. MRI is almost 100% abnormal, but it is not specific. Mass lesions are in 5%, meningeal enhancement in 8%, and ICH in up to 9%. The angiogram, the non-specific pattern of beading, aneurysm, circumferential or eccentric irregularities, which are much commonly brought out by the advanced neuroimaging techniques, which I'll describe later. Multiple occlusions. The sensitivity is only 40 to 90%. The specificity is 30%. This is what I'm going to tell you. The vessel wall imaging is very big help nowadays. This technique is high resolution MRI, and that may improve specificity of MRI in distinguishing PACNS from its major differential diagnosis RCVS by visualizing the vessel wall. And of course, gold standard is pathological diagnosis, which also has its own limitations. Third heuristic is non-vascular imaging. Non-vascular imaging, as I said, is highly sensitive and thus has high negative predictive value. Means it can rule out the disease. Because if there is something, then you can think of vasculitis. If there's nothing, but if it is some abnormalities there, it is not specific, you can't confirm that it is because of the vasculitis. So you can see a number of things: multiple ischemic lesions, hemorrhages, leukoencephalopathy, GAD-enhancing lesions, parenchymal, leptomeningeal. Of course, the choice is you have to do a GAD and a diffusion weighted image. So the point to take is highly sensitive, low specificity. It is non-vascular imaging. If you look at the vascular imaging, the direct or indirect, cerebral angiography is the radiological gold standard, but not the real gold standard for identification of primary CNS vasculitis. There is no angiographic study which is 100% specific for the diagnosis. The typical findings, as I said earlier, stenosis, ectasia, beading in multiple vessels, alternating segments of stenosis with normal or dilated intervening segments, arterial occlusions, delayed arterial emptying, anastomotic channels, microaneurysms, occasionally. The angiographic findings, which are compatible with vasculitis, might be encountered in several non-vasculitic disorders, such as vasospasm, CNS infection, cerebral arterial and atherosclerosis. So that's why I'm saying the vasospasm, RCVS, is a main differential diagnosis for primary angiitis of CNS. DSA, in many cases, both large arteries and smaller arteries are affected. The sensitivity varies, decreasing in small vessel size. It's not very useful if the small vessel vasculitis is dominating. A limit of angiography is of low specificity. Specificity is poor, 26% in suspected cases. Positive predictive value in biopsy-proven cases is only 50%. MRA is less invasive than angiography in detecting lesions, and especially in PCA and distal vessels. MRA, however, overestimates the severity of stenosis at points of vessel branching or vascular occlusion. That means we have limitations in our interpretation of the tests. You can see these are the abnormalities that you can see in vasculitis, which is highly sensitive and low specificity. And you can see the basilar artery here, which has got narrowing, alternate constrictions and dilatations at various places, and the vertebral artery also. And you can see the right ICA has got constriction, and you can see the MCA cutoff and beaded appearance in MCA. So these are the angiographic findings. You can see in the thin right vertebral with multiple areas of stenosis. You can see, and this you can see these arrows which are showing some stenosis, thin left vertebral, multiple areas of stenosis. You have to carefully read the angios. For constrictions, you have to see clearly, carefully. You see everything appears normal to us unless we have that clinical mindset to look at angios and identify various features. So vessel wall imaging is a heuristic for advances that have helped us. This is a high resolution, high field MRI, 3 Tesla. What it does is it visualizes the wall of the intracranial blood vessels. The vessel wall enhancement and thickening, which is seen in PACNS, how it is differentiated is atherosclerotic is eccentric, vasculitis is concentric. I'll show you some radiology images about that. Vessel wall thickening and intramural enhancement of large arteries. These are specific for primary CNS vasculitis. Occasionally, enhancement can be very noticeable and it extends into the adjacent leptomeningeal tissue when we call perivascular enhancement. RCVS, on the other hand, which is a main differential diagnosis, has no mild or no vessel wall enhancement. So Mild or no vessel wall enhancement is RCVS, and PSCNS has got vessel wall enhancement and thickening with high resolution MRI. This is a take-home message. You can see that. You can see the high resolution MRI brain coronal section pre and post gadolinium contrast in the same vasculitis patient. Wall thickening and enhancement you can see here. You can see here the vessels, and here see the vessels which have got thickening of the walls. So this is the characteristic feature, concentric thickening. And you can see the high resolution MRI brain axial sections, post gadolinium contrast, vasculitic patient, and shows vessel wall enhancement and thickening. This is the vessel wall enhancement and thickening. And while RCVS patient, you can see there is no vessel wall enhancement. This you can see here. So this is the vasculitis versus RCVS, how you differentiate. Then the same things, CNS vasculitis, which I have shown you. This is how you see, you look for enhancement after, but this is RCVS, there is no enhancement. So the 7 heuristics of CNS vasculitis now comes to 5th one, that is brain biopsy. Where do we say, where do we stand about brain biopsy? Brain biopsy is underutilized, but is a valuable, imperfect diagnostic tool, I should say. There are 2 reasons for it. To rule in, that is positive predictive value, high specificity, it is there 90 to 100%, but low sensitivity 60 to 70%. To rule out other conditions, mimics are detected in 39%. So what we should do is an open biopsy with overlying leptomeninges and cortex and white matter to be included in the biopsy specimen. Blind biopsy of non-dominant temporal poles, which is to be the practice, is not preferred anymore. And so the cortex and white matter, the open with overlying leptomeninges preferred for blind biopsy of suspected granulomatous CNS. And how much? 1 centimeter cube of non-dominant temporal lobe, compassing 1 gyrus at least. It was the usual practice. And stereotactic preferred for targeted biopsy can include leptomeninges. Now we change our technique from the blind biopsies to the area of involvement. So does it help us? An optimal biopsy should include samples of dura, leptomeninges, cortex, and white matter. Transmural inflammation of small and medium-sized leptomeningeal and parenchymal arterial vessels. There are segmental and skipped vascular lesions. As I said, sensitivity is 40 to 90%, specificity is less than 30%. So biopsy of a radiologically abnormal area is preferable to random sampling of the non-dominant frontal lobe or temporal tip. Earlier, we used to do that. Targeted biopsies, 78% diagnostic. Blind biopsies, 0. So perivasculitis and vasculitis, that is injury to multiple due to multiple etiologies in brain, is angiocentric. That is infection, hypoxia, and trauma. They are all angiocentric. Primary CNS vasculitis is a vasculitis histologically affecting small and medium-sized leptomeningeal and parenchymal arterial vessels. So the true vasculitis has got a transmural inflammatory vascular damage, which you keep on seeing on the all times. There is a concomitant beta amyloid deposition. So there is a correlation between Alzheimer's disease and vasculitis because of the beta amyloid deposition. So the biopsy brought out 3 patterns. So one is granulomatous pattern, which is most common, and amyloid deposition is the well-formed granulomas are seen. Second, which Dr. Salaja's group has found, lymphocytic, typically reported in children with angiography negative primary CNS vasculitis. Necrotizing, similar to PAN, that intracranial hemorrhage is more common with this. So brain biopsy histopathology patterns, the granulomatous vasculitis, which you can see, there is a transmural inflammation of leptomeningeal artery with the prominent mononuclear and granulomatous adventitial inflammation. You can see the inflammation in the adventitia also, and local, there is a fibrin deposition in this. And second picture, granulomatous pattern with beta amyloid deposition in this. And third, intraparenchymal arteries with the transmural inflammation with vessel wall destruction and also granulomas. Both vessels show amyloid deposition. So there is a close correlation with Alzheimer's disease. Brain biopsy, histopathology pattern there are two more patterns. We have seen earlier one, granulomatous pattern. Now it is a lymphocytic pattern, which is seen in 28% cases. Leptomeningeal vessels show marked transmural lymphocytic infiltration, devoid of granulomas and histiocytes. That's why it is called lymphocytic vasculitis. Necrotizing is seen in 14%. Intraparenchymal muscular artery shows extensive mural thrombus with karyoretic debris and acute neutrophilic inflammation. And these type of lesions are leading to ICH. So CNS vasculitis heuristic rule 6. You have to must rule out. You should rule out viral, that is varicella zoster infection, HCV, HIV, CMV, mycobacteria tuberculosis, fungi, rickettsial, spirochetes, parasites, acanthamoeba, and maybe COVID also we should know. We don't know right now. Intravascular lymphomas, CNS lymphoma, leptomeningeal metastasis of a solid tumor, all have to be, the mimics have to be ruled out. And there may be other conditions which are maybe systemic vasculitis, Sjogren, sarcoid, paraneoplastic, and the embolic, the myxomas, atrial fibrillation, subacute bacterial endocarditis, hypercoagulable disorders, brain disease with abnormal MRI like lymphomas, microvascular ischemias, and CADASIL, MELAS, and this Suzak syndrome, etc., etc. So many things you have to. Why I say this is a zebra diagnosis. What we PSCNS is a zebra diagnosis, and why this is a radiation vasculopathy, which also can mimic the PSCNS. Neurosyphilis can mimic. Complete also signal in the basilar artery. You can see that is a stenotic segment, and neurosyphilis, and you can see various areas you have got stenosis. So advanced MRI for cerebral arteries and neurosyphilitic vasculitis, severe stenosis with basilar artery, top image, right parenchyma, chronic infarct is seen, basilar wall enhancement and narrowing of mid-basilar. There's a post-GAD fat suppressed saturation band is seen. So these are the advanced techniques which will help us in differentiating. The most important is RCVS, reversible cerebral vasoconstriction syndrome, which is characterized by acute onset headache, followed by a monophasic course without any complications after 4 weeks. So till 4 weeks, there may be complication of infarct or hemorrhages. PSCNS onset is more insidious, course is progressive with frequent cerebral infarcts. The MRI is often normal in RCVS despite severe headache, but normal MRI excludes, as I said, PSCNS. So you can see the RCVS brain hemorrhages can happen, but this disorder is characteristically within 4 weeks time. So there are some differentiating features. The precipitating factors for primary CNS vasculitis is nothing. Whether postpartum onset or onset after exposure to vasoactive substances, RCVS is commonly observed. More insidious and progressive course in PSCNS, and acute onset followed by a monophasic course in RCVS. Chronic and progressive headaches, here acute and thunderclap type of headache. And CSF is abnormal, normal to near normal in RCVS. MRI is abnormal in all cases of primary CNS vasculitis. It is normal in 70% of the patients in RCVS. Angiography is where the problem comes. It's possibly normal. Otherwise, diffuse abnormalities are often indistinguishable from RCVS. Irregular and asymmetrical arterial stenosis or multiple occlusions are more suggestive of primary abnormalities, might be reversible. In RCVS, the angiography is always abnormal. Strings of beads appearance of cerebral arteries, abnormalities reversible within 12 weeks. So cerebral biopsy, vasculitis, no vasculitic changes. Drug treatment, prednisolone with or with, here it is nimodipine. So last treatment, CNS vasculitis treatment, there is no control data. Historical bias is there. Biopsy proven disease is based on burden of morbidity. What is the drug that is used? So granulomatous pathology responds to glucocorticoids and cyclophosphamide. We call it Wagner GPA protocol. And biologics, there is a role for anti-TNF, as I said earlier, and rituximab. Duration of treatment is 6 months to 1 year. Failure to respond Our progress on cyclophosphamide and glucocorticoid suggests an alternative diagnosis to be considered rather than refractory disease. Mind you, this is the important point which we have to mention. So, empirical treatments, and there is something which we all should know. Under conditions of diagnostic uncertainty, empirical treatment is indicated for all the diagnoses whose probability exceeds their treatment threshold. The probability of a disease at which there is no clear advantage for either empirical treatment or no treatment, that is the threshold. And their potential benefit is very great. So primary CNS anxieties is a very rare disorder. Diagnosis of this condition is so-called zebra diagnosis. You always prompt skepticism because common presentation of a rare disease is less likely than a rare presentation of a common disease. So I emphasize again, primary CNS anxieties is a diagnosis of exclusion. It cannot be made until all other secondary causes are disproved, especially infectious diseases. So a treatment course of 12 to 18 months is adequate in most patients. In patients with severe progressive primary CNS vasculitis, that is life-threatening, high-dose methylprednisolone for 3 days and cyclophosphamide can be used. Repeated pulses also can be given, and resistant to glucocorticoids and immunosuppressants. Other treatment options are infliximab, long-term etanercept, and anti-CD20 therapy with rituximab. These are the things. The induction is prednisolone 1 milligram per kg body weight, cyclophosphamide 2 milligrams per kg day oral daily, monthly once IV 0.75 grams for the meter square. So that is, but there are no randomized clinical trials and the management of this. And maintenance is azathioprine or methotrexate or mycophenolate mofetil. So their treatments have been studied by various groups, the Selvarani group and others. So they got their own. So the subset treatments are also described where you have to use more aggressive therapy. If it is prominent leptomeningeal enhancement, what you should use, angiography negative, what should you use, cerebral amyloid angiopathy is seen, what you should use, rapidly progressive ones. And when spinal cord involvement is there, consider adding cyclophosphamide and presenting with intracranial hemorrhage. And then you have to have very careful, similar to general treatment, but tumor-like lesions, also prednisolone with cyclophosphamide. So there are areas where you have to use TNF blockers, infliximab, etanercept, and adalimumab, and other drugs. So high-dose steroids with a long, slow taper, no, not a validated one, and 15 milligrams per day for at least 3 months, and some rheumatology, cyclophosphamide in the conventional doses, and mycophenolate mofetil 1 to 2 grams per daily. So prognosis, relapses and recurrences were recorded only in 26% of the patients in Mayo Clinic series. Patients with relapsing disease need therapy for longer than those with non-relapsing disease, but otherwise had outcomes similar to those without relapses. Serial MRIs and MRAs 4 to 6 weeks after the beginning of treatment, then every 3 to 4 months during the first year of treatment. In patients with stable imaging but worsening clinical symptoms, repeat spinal fluid examination and repeat angiography might be necessary to rule out other diagnoses. Those patients without biopsy at the time of initial diagnosis who have worsening symptoms despite immunosuppressive therapy, a brain biopsy should be considered. So the diagnostic criteria now, I'll summarize here that those are by Calabresi and Malek, a history or clinical findings of an acquired neurological deficit which remained unexplained after a thorough initial basic evaluation, either classic angiographic or histopathological features of vasculitis within the central nervous system, no evidence of systemic vasculitis or any other condition to which the angiographic or pathological features could be secondary. A diagnosis of primary central nervous system vasculitis is made. All the above criteria are satisfied. The Birnbaum and et al., they defined confirmation of vasculitis on analysis of a tissue biopsy specimen, whereas the angiographic findings and histological findings are also given importance in Calabresi. So there is a slight difference in both the criteria, but we have read or we have known now all the various nuances of these various diagnostic criteria. So let us say that the non-specificity of CNS angiograms can result in patients with syndromes of RCVS being misdiagnosed and treated for PSCNS. So we have to be very careful. And one of the CPCs I have done in AIMS, New Delhi, I diagnosed it as RCVS, but on the third biopsy, the case was diagnosed as primary anxieties of CNS. So CNS vasculitis and Alzheimer's disease, as I was telling you, in an 81-year-old man who presented with cognitive decline, unsteady gait, and visual hallucinations, which progressed for 3 weeks. Past medical history of seizure and a history of ruptured right midcerebral artery aneurysm with subsequent encephalomalacia. Severe cognitive impairment with MoCA 5/30, no evidence of focal motor weakness, but due to attention and cognitive deficits, he cannot fully participate in confrontational testing. Visual fields appear intact, normal fundoscopic examination. This is the MRI of this man. Let us look. A beta related anxieties with evidence of granulomatous arthritis of leptomeningeal vessels is associated with the multinucleated giant cells and beta amyloid, which I have shown you in the biopsy specimen. And PACNS and cerebral amyloid angiopathy are generally regarded as unrelated disorders. But in a minority of patients, these has been described as a distinct clinical pathological disorder as a form of CNS vasculitis, part of a widespread immune reaction to A-beta within the CNS. A-beta amyloid immunization in Alzheimer's disease has brought to light these patients with the subacute meningeal encephalitis cases. That postmortem studies severe cerebral amyloid angiopathy as well as meningeal and perivascular inflammation is seen in these cases where vaccine was given. So that closes our discussion with PSCNS. Now we'll go to SLE. Historically, many terms were associated with SLE affecting the nervous system, like lupus cerebritis, neurolupus, CNS lupus, lupus sclerosis. But presently, the term used is neuropsychiatric SLE or NPSLE. And NPSLE and neuropsychiatric syndromes observed in systemic lupus erythematosus are many. If it is CNS, aseptic meningitis, cerebrovascular disease, demyelinating syndrome, headaches, movement disorders, chorea especially, myelopathy, seizure disorders, acute confusional states, anxiety disorders, cognitive dysfunction, mood disorders, psychosis, etc. And peripheral nervous system, Guillain-Barré syndrome, autonomic disorders, mononeuropathy, other multiplex, mononeuritis multiplex, myasthenia gravis, neuropathy, plexopathy, polyneuropathy, neuropathy, especially cranial nerves. So 19 syndromes are named to provide standardized nomenclature that does not imply causation by SLE. Other syndromes not named but have been observed also. So though they are observed, they are not, cannot be directly related. What is SLE? It's a chronic multisystemic inflammatory disorder. It disproportionately affects women and relatively common, 50 per 1 lakh people in US. It has got unclear pathogenesis. There are genetic susceptibilities, environmental factors such as EB virus or drug exposure. Women of childbearing age may have influence of hormones. The disease characteristics are autoantibody against cellular antigens. ANA is present 95%, but is not specific. Anti-double-stranded DNA can correlate with disease activity. At least more than 100 autoantibodies have been described. Immune complex of antibodies and cellular debris is seen causing nephritis, and antiphospholipid syndrome antibodies are also autoantibodies, and some type of rash is seen because of vasculitis. And there is accelerated vasculopathy and chronic immune activation. See, here we have to observe that is it vasculitis or vasculopathy? So mainly these people present with fatigue, episodic fever, myalgias, and weight loss. There is often photosensitive skin rash, butterfly rash, sparing the nasolabial folds, and which is a variable in its distribution. There may be oral and nasal ulcers, arthralgias, non-erosive arthritis, pleuritis, or pericarditis, and serositis, and nephritis. So cytopenias, hemolytic anemia, decreased white blood cell or lymphocyte count, thrombocytopenia, antiphospholipid antibodies, low complement levels, ANA, anti-dsDNA, anti-SM may be positive. And what the stupor was reported way back in 1874 by Hebra and Kaposi. And Osler speculated on CNS vasospastic disease. What he said is, it seems not improbable that these transient attacks were due to vascular changes in the brain, the counterpart of those occurring in the skin. So lupus vasculitis as a cause of symptoms was thought, but it could never be proven in any autopsies. So, but Libman-Sachs endocarditis, one of the features which can cause cardioembolic strokes, because strokes are commonly encountered in SLE. Johnson and Richardson described 24 autopsy neuropathological cases. The most common are microinfarcts with microglial nodules and arterial thickening. The vasculopathy with no cases of generalized arthritis. Other autopsy series also report lack of arthritis, but there is thickening of vessel wall. Hemotoxylin eosin studies are not sensitive to disorders affecting neuronal function, which is based on the ion exchanges such as signaling changes. So what can affect these is antiphospholipid antibodies, anti-NMDA or NR2 subunit antibodies, anti-ribosomal P antibodies, and coporin 4 antibodies, anti-MOG antibodies also seen in these cases. The prevalence of nowadays what we call NPSLE, neuropsychological SLE syndromes, is 56%. 28% have a neurological complaint at the time of diagnosis. The prevalence of syndromes, you can see, headache is 57% up to, mood disorder 40%, cognitive 80%, cerebrovascular disease 50 to 60%, seizures 10%. Can the syndromes be attributable to SLE? No, we cannot. But we have to be careful when we are dealing with stroke in anger. Majority of studies do not find relation between headache and SLE activity. There is no relation between serum anticardiolipin antibodies and headache. So lupus headache is in isolation is likely not a marker of the disease activity, but frequently headache can be because of the cerebral venous sinus thrombosis, and this headache is similar to studies in general population. So prevalence of major depression is also another important aspect, which is seen up to 47%. But in these studies, there are many methodological flaws, type of interviewing, criteria used, etc. There is an increased prevalence from chronic illness, disability. So elevated disease activity modestly increases odds of major depression by 10%. It is probably related to SLE, but there are many confounders, so it's not a diagnostic entity. Psychosis, 1,826 patients, inception SLE cohort followed for average of 7 years. And psychosis is a rare event, mostly attributable to SLE in 1.5%. Majority of cases occurred within the first year of disease. Anti-ribosomal P antibody diagnosis and follow-up is not associated. Most cases of psychosis resolved completely on follow-up. So psychosis, CSF and MRI of brain do not have specific findings. Is the psychosis from corticosteroids? If it is dose dependent, 19% if this is more than 80 milligrams per day of prednisolone, 1.3% if less than 40 milligrams. Auditory hallucinations are more common in steroid. Visual hallucinations are more common in SLE. That's a differentiating feature. It's often related to disease activity. First, check for steroid psychosis and you look at the dose that is being used. Otherwise, auditory hallucinations are more common in steroids. Treat SLE, including with steroids and antipsychotics otherwise. Seizures. Can there be seizures in SLE? Can be from SLE generalized and focal seizures can when attributable to SLE typically occurs early in the disease course. Late seizures are not due to SLE, but maybe because of stroke or other factors like uremia, lupus nephritis. Most frequently, they are single episodes, and seizures do not always require AEDs. Decision is based on imaging, EEG, and patient discussions. Stroke accounts for 10% of deaths in SLE. One of the leading individual cause of death after bacterial sepsis is stroke. Increased risk of stroke, that is 21-fold increased risk in 30 to 39 age groups. This is mostly a small vessel vascular disease also seen, reported early in the neuropathological series. Now on MRIs, T2 hyperintense lesions, not explained by conventional risk factors like hypertension or diabetes, and it correlates with cognitive dysfunction. And this hyperintensities can be measured by diffusion tensor imaging. So small vessel vascular disease, as you can see in this, These are more common, and histopathology also you can see the small vessel vascular diseases, and you see the infiltration, and you see the image abnormalities, and hypercoagulability and embolic infarcts. And hypercoagulability, SLE itself is a risk factor for thrombotic events. The risk is higher for venous thromboembolic disease. It is less robust epidemiological data on arterial thrombotic risk. Antiphospholipid syndrome is commonly present in patients with SLE and stroke. Embolic infarcts, as I said, limb and sacs endocarditis or infectious endocarditis, or a paradoxical emboli, or an artery-to-artery embolism. These are the important things. Microembolic signals are also observed on TCDs in 9 to 15% of the patients with SLE. They have microembolic signals when monitored for an hour over the middle cerebral artery. So that's another clue that embolic infarcts are happening in this disease, and they are associated with ischemic infarcts. Prevalence is not explained by carotid stenosis or antiphospholipid antibodies. So we have to treat aggressively these cases. And atherosclerosis is accelerated in SLE. Increased prevalence of risk factors such as hypertension, diabetes, dyslipidemia. There is an elevated risk of atherosclerosis in SLE, even controlling for these factors. Vasculitis, as I said, does it exist? Yes, but very rare. Individual cases exist in the literature. It is not vasculitis, it is a vasculopathy. So check for antiphospholipid antibodies, that is lupus anticoagulant, anticardiolipin IgG, IgM isotype, anti-BT2 beta-2 glycoprotein, and screen for infective limb and sacs endocarditis. SLE is not a contraindication for IV TPA for acute stroke, and control of modifiable risk factors as with other strokes, generally treated with antiplatelet agents for secondary prevention unless antiphospholipid syndrome is where warfarin is used. There may be some cases with intractable nausea and vomiting. 14-year-old girl with a diagnosis of SLE, arthralgias, pleuritis. ANA titer is very high. Serology is positive for anti-dsDNA, anti-Ro, and it is controlled with hydroxychloroquine and methotrexate. Presented with intractable nausea, vomiting, no identifiable GS source found, but you can see that area prostomal lesion that is enhancing aquaporin 4 positive. So these also can coexist. Longitudinal myelitis, you can see here, longitudinal enhancing spinal cord lesions are seen in cases of SLE, and aquaporin antibody negative in these cases. So longitudinal myelitis, another presentation, important to consider concurrent multiple sclerosis and neuromyelitis optica. Emerging data suggests that SLE systemic activity distinguishes SLE myelitis from MS and NMO, and this is a monophasic illness unlike NMO. And there is a sign also which we can see, the central vein sign, which is SLE and brain lesions, likely comorbid MS. Central vein in the lesions, you can see the central vein sign, and this threshold of 40 to 50 discriminates between multiple sclerosis and other inflammatory vasculopathies. If you find central vein that is on the GRE sequence, it goes in favor. You can see that MS has got very high prevalence of central vein sign. That's another important aspect. And neural antibodies, they are found in 13%, most frequently anti-MOG and anti-NF186. Only 35% had antibody-associated clinical syndrome. It's an emerging field. Be cautious of interpreting positive results in patients with SLE. More data to come with large cohorts. And hyponatremia, as I can say, you see that with hypophysis involvement, which can cause hyponatremia in these cases. So that brings us to antiphospholipid antibody syndrome, and prothrombotic state is associated with autoantibodies. It can occur in the context of autoimmune disease such as SLE or be primary, and or it can be primary by itself. An important cause of acquired hypercoagulability. The lupus anticoagulant positivity, it is anticardiolipin IgG or IgM, which is present in high titers, and the measurements need to be repeated at least 12 weeks apart to be considered definite. Transient positive results are not specific, as you can see the controls. The controls without clinical thrombotic events, higher rates of positive antibodies in winter months is seen in normal individuals also. So it is not very diagnostic as such. The clinical criteria, arterial or venous thrombotic event in any tissue or organ. Pregnancy complication, very interesting. One or more unexplained deaths of a healthy fetus beyond 10th week of gestation. one or more premature births of normal fetus before 34th week from eclampsia or severe preeclampsia, 3 or more consecutive unexplained spontaneous abortions before 10th week. So antiphospholipid antibodies, monocytes, endothelial cells, you see the platelets, they cause expression of adhesion molecules, upregulation of tissue factor production, which brings out a thrombogenic state. Monocytes, upregulation of tissue factor production, platelets, expression of glycoprotein 2B3A, upregulation of thromboxane A2 production. These all lead to thrombogenic state, and interaction with coagulation regulatory proteins like protein C, prothrombin, plasmin, that will cause thrombosis, and complement activation and other coagulant conditions also contribute to thrombosis. So neurological complications, arterial ischemic strokes associated with thrombosis affecting large or small caliber arteries, cardioembolism, which can be from limb and sacs endocarditis if it is present in SLE. Paradoxical embolism can happen from deep venous thrombosis through persistent foramen ovale, cerebral venous sinus thrombosis. Other possible associations which are very, there lack evidence, epilepsy, chorea, psychosis, myelitis, hearing loss. There's something called a catastrophic antiphospholipid antibody syndrome, a subset with widespread thrombosis, presence of antiphospholipid antibodies, 3 or more thrombotic events in a week, and biopsy confirmation of microthrombotic events. And these patients require immunosuppression, steroids, and cyclophosphamide. So asymptomatic carriers, management is unclear, no therapy or aspirin. With a venous event, anticoagulation with INR 2 to 3. With arterial event, this is again a problem where we are not sure, area of controversy, INR 2 to 3 with aspirin versus higher INR target 2.5 to 3.5. Arterial event with low titer antiphospholipid antibodies, usual treatment. Steroids and plasma exchange, IV is used for catastrophic APS. So there is no role for rivaroxaban, which has been studied, and a higher risk of breakthrough thrombotic events in rivaroxaban. So most frequently arterial ischemic events happen. So it was given warfarin is preferred drug. The last one is Bechets disease. It's a multisystem inflammatory disease of unclear etiology and geographically high incidence from Mediterranean and along the ancient Silk Road to Eastern Asia. I'll again tell you the countries in the next slide. Less common in other areas. Increased risk with HLA B51. Pathology shows leukocytoclastic obliterative perivasculitis affecting vessels of multiple calibers. Thrombosis often present in the vessels. It's a systemic vasculitis. Like primary venous insufficiency disorders, which are Bickerstaff encephalitis and neurobechets, brainstem suffers immune attack. The Bechets disease is also known as Silk Route disease because its prevalence is more in the ancient silk trading route of Turkey, Iran, Iraq, India, Pakistan, China, Korea, and Japan. Neurobechets is common in the age group of 20 to 40. Pathophysiology is aberrant immunoreactivity, which is triggered by an unknown infectious agent. It affects the blood vessels of all sizes, small, medium, and large. HLA B51 is the association, is very well known. What are the major criteria? Oral ulcers at least 3 times a year. Genital ulcers are scarred. Uveitis in 70%. Erythema nodosum, folliculitis or acne, and positive pathology test. These are skin tests. Minor criteria: arthritis, DVT, superficial thrombophlebitis, and epididymitis. So the 98% sensitivity is given for oral ulcers, 74% genital ulcers, skin changes 70%, and ocular lesions 55%, and arthralgias 51%, and thrombosis and phlebitis 19%. So there are the criteria, inflammation, the international criteria for Bechets disease. There's a point scoring system. Score of more than 4 indicates Bechets diagnosis. Highest weightage is given to ocular lesions, genital aphthous ulcers, oral aphthous, and skin lesions, neurological manifestation, vascular manifestation, but they're all given 1. So neurology, nervous system affected in about 15% of the patients in different series. In case series, men more commonly affected than women in a ratio of approaching 3:1. Onset is generally between 20 to 40 years old, and the more than 90% cases usually not the first symptom of the Bechets disease. Parenchymal, non-parenchymal, peripheral nervous system, 3 areas: brainstem, spinal cord, cerebral, meningeal involvement. In non-parenchymal cerebral venous sinus thrombosis, intracranial aneurysms, usually peripheral nervous system is not affected. The brainstem lesion often extends superiorly to thalamus and basal ganglia. You can see here. And parenchymal disease is usually subacute onset, often with systemic symptoms, headache, signs of meningeal irritation, multifocal nervous system involvement, acute inflammatory lesion generally enhanced with IV GAD. Cerebral spinal fluid is usually abnormal. Protein is generally elevated. CSF cell count can be very elevated and range early neutrophil predominance to latest lymphocytosis. Oligoclonal bonds are usually absent. So this is a Bagel sign, which you can see the Bagel sign here. In this case, on T2 imaging, hypointense core with hyperintense rim, Bagel sign can be found in spinal cord lesions. Alternate pattern can be anterior horn selective hyperintensity. So this is a very important Bechets disease sign, Bagel sign. So non-parenchymal, generally less common than parenchymal, that is CVST, progressive headache and signs of intracranial hypertension. Systemic symptoms not always present. CSF is usually bland. Intracranial aneurysms, rare to be isolated sign of the disease. Also significant background rate of incidental aneurysms in these cases. Management, no randomized trials to guide therapeutic choice based on expert consensus. Pulse dose steroids with prolonged steroid taper over multiple weeks is generally the first line therapy. Steroid refractory disease or aggressive disease, consider adjunctive therapies, anti-TNF therapy with infliximab, multiple series. They confirm benefit. Azathioprine, methotrexate, and mycophenolate mofetil all have been observed to be of benefit. For venous thrombosis, optimal therapy and balance between anticoagulation and immunosuppression is unclear as on today. So I conclude my talk by saying that neurosarcoidosis, we have to be very careful. We have to look at so many things and mimics and MS and PSCNS is a zebra diagnosis, as I said earlier, and the rare presentation of a common disease is more common than common presentation of a rare disease. Neuropsychiatric SLE is a heterogeneous group of symptoms, not always casually linked with SLE. Neurology of SLE has broad array of mechanisms. Anticoagulation is primarily therapy for antiphospholipid syndrome with caution in interpreting data from trials, primarily with venous events. Parenchymal Bechets disease is subacute syndrome, usually with brainstem involvement, as with all venous insufficiency syndromes like Bechets encephalitis. I think I'll stop here, and if anybody is there and wants to ask some questions, we can ask questions. So we have covered SLE, and we have covered neurosarcoidosis, primary anxieties of CNS. So, and if there are any questions, you can ask. Otherwise, I think there are no questions. Yes, there is something. Okay, thank you very much. That's okay. And if there are any questions, you can send me by my email, which I'm going to type here. Just remove it. Okay, then. Good night. Thank you very much.